We're wonderfully moderated by Lydia Boriba, who took up the charge to provide this awesome link for us all between planet and people. So I'm going to immediately turn things over to her.
All right. Okay, it works. Fantastic. Thank you so much. So it's I saw some of the morning session. I think it's fantastic to have this panel as a link between the planet, the health of the planet and health of the people. So I'm Lydia Boriba. My research is at the intersection of really physics and health, if you will, the fluid dynamics and infectious diseases or all sorts of ecological diseases. And we combine essentially physical approaches, very much so at various scales, to epidemiological and also indoor health and indoor space aspects related to human health. So I will stop there about my research, and really the stars of the hour are the panelists. And so we have four fantastic panelists. On my left, Dr. Colin Stoltz. Professor Stoltz is both MD and PhD, currently the Nina and Robin Professor in Medical Engineering and Science, Professor of Electrical Engineering and Computer Science, Associate Director of IMSS. He's also the co-director of the Harvard-MIT Health Science and Technology program, while also being practicing cardiologist. So I have no idea when he sleeps, but it's going to be fun. So his doctoral training is in biophysics, and his research currently focuses on the development of machine learning tools that can guide clinical decision making. So we'll start with him, and then we'll have, therefore that's a focus on the human health. We'll have Sherry, who is professor in mechanical engineering and IDSS. Professor Wang is the Albert Career Development Assistant Professor. Her doctoral training is in computational and mathematical engineering. Her research currently focuses on improving agricultural management and mitigation of climate change, especially in low and middle income regions of the world, combining novel and combined data streams and modalities, and developing new algorithms to gain insight on refining or even designing new metrics for environmental health. Our third panelist will be back to human health squarely, cancer research. So that is Professor van der Heijden. Professor Heijden, is that the right pronunciation?
It's van der Heijden.
Van der Heijden, okay. So van der Heijden.
Call me whatever.
All right. Also MD, PhD, currently the Lester Wokfi Professor of Molecular Biology, member of the Board Institute. He's the director, actually, of the Koch Institute. And his research focuses, in addition to being practicing oncologist, so another one that probably sleeps very little. So his doctoral training was in cancer biology. His research currently focuses on cancer cells and their metabolic requirements to advance metabolic pathway biochemistry. And as the director of the Koch Institute, he has reflected extensively on the role of AI in the cancer space and research for medical applications. And finally, our last panelist is Anna Maria Wagner. Anna Maria Wagner is currently the SVP of Corporate Development at Ginkgo Bioworks. Her training was in applied mathematics and economics and business administration. Her company, Ginkgo Bioworks, designed custom microbes for customers across multiple markets and application fields. So we have both the human health and the environmental and climate maybe angle. And in developing new organisms that replace technology with biology and heavily relies on AI to do so. So with that all being said, I will essentially pass the floor to them to kick off the discussion on really their research in that space that is both human health and environmental health, I want to put it that way, and the role of AI in their fields, including the key challenges, opportunities, and potential concerns that they see.
So thanks. I guess I'm first up at bat. So my focus on this is a little bit different. I'm a clinician, sees patients across the gamut with cardiovascular disease, and my research here at MIT is at the intersection of artificial intelligence and health. I very much enjoyed the morning session, and I will say that the connections between climate change and cardiovascular health are clear. The causal relationship is not so much, but the connections are clear. There's some data to say that 1 degree increase in the temperature over the planet is associated with a 4% increase in cardiovascular mortality, so that's clear. My interest, however, is in sort of the other side of the coin, is how do we make people better using this technology that has been discussed earlier today. So in all of medicine, no matter what the area is, only two things that people want to do: make you live longer and make you not feel pain, right? And how can we leverage AI to accomplish those tasks? So instead of focusing on the work specific in my group, I would just want to elevate the conversation to deal with it from that point of view. If you read, like I said, I was going to say read the newspaper, but nobody reads the newspaper anymore, right? So if you open up your favorite website that talks about the news and you try to read something about AI or ML, you'd believe that it solves everything. It solves all of the world's ills. But in medicine, it's quite different. I think there's a lot of promise in these methods, and in particular in the generative AI, which is the new buzzword that has been going back and forth today. But I think it's important to take a healthy skepticism with these methods, with these black box methods that I am a developer of, my group is a developer of, and I believe in their future. But I think having a realistic view of what they can do and their limitations, if there's nothing else that I can leave this colloquy with, that's the one thing that I would. So I'm approaching this discussion as a learned, I think learned maybe is an appropriate term, skeptic. And I'll leave it there.
All right.
Thanks
Sherry.
a lot for having me. So as Lydia mentioned, my work is at the intersection of sustainability, sustainable development, and artificial intelligence or machine learning. And there are so many opportunities at this intersection, as you've seen earlier today as well. But I'll just highlight a couple that I think are quite promising. So in our group's work, one main area is using ML to synthesize vast amounts of data that we have access to now that we haven't had before. So one example that we work a lot with is satellite or remote sensing data. So there's these satellites orbiting our planet now and collecting tons and tons of information. And more satellites are being launched every year at higher and higher resolutions. And we really need algorithms that can extract knowledge from that data. And a lot of the applications we work in, I think something I would love to talk a little bit more about in today's panel is a lot of the applications have very few ground labels, actually. So we're not really in the regime of these large language models that you see today that are trained on the entire internet. It's worth of images or text. We're talking about applications, for example, melting glaciers or what people are planting on the ground in sub-Saharan Africa. There's so many applications in the earth sciences, environmental sciences, sustainable development, where the actual ground truth that we have is very few. So something my group is interested in is how can we still use these AI ML tools to make progress in such applications that are very important, but we don't actually have a lot of labels for. Another area I think is very promising is expanding the kind of availability of information using these large language models that we now have. So with ChatGPT now having capabilities in multiple languages and speech capabilities, we're starting to see, for example, agricultural extension services that can disseminate information to farmers, not only using on-the-ground workers, which is traditionally what has happened, but you can now deliver an extension service to a farmer's phone using something built on top of ChatGPT or similar kind of models. So I think that's also another very promising area for development, but would be happy to explore these further in today's panel.
All right, Matthew.
Okay, great. So first of all, nice to see all of you. So I am not going to tell you about my research because that is not why I'm here. I'm here mostly because of my position as director of the Koch Institute. So the Koch Institute is where you guys are. It's MIT's Cancer Center. And we really try to be a model of how do we use multidisciplinary approaches from engineering, physical sciences, life sciences to really come together to solve big problems in cancer. And obviously, one of the big ones there is what is the opportunity in AI machine learning and cancer, and we should be the leader in that space. And so I think about this a lot, and really what are the ways in which AI or machine learning really can be applied to really solving problems as they relate to cancer. Now, like Colin, I can't help but view this also through the lens as someone who is a physician and sees patients and knows the realities of what goes on in the hospital. And I can tell you there's many applications, some developed here at MIT, of machine learning on cancer biology that are clear and exciting and should be explored further. These are things like radiology reading, pathology reading, prediction of earlier disease, better stratifying patients for outcomes. Those things are clear because these are examples of things where images are taken as part of standard medical care, and one can take algorithms that can classify images in a way that allows one to use that in a way to extract information that wasn't there before. Lots of people are doing this now. Excited to explore with you guys what we can and cannot get from those things and where the shortcomings are. That may come up later in the discussion. But as we think about what are the more forward-looking opportunities, it's very easy to say, oh, AI is going to solve all of our problems. But I think if one really sits down and thinks about the reality of where some of the bottlenecks and challenges are, there's some big things there that at least I think we need to figure out if we're really going to make impacts in medicine, and excited to have a discussion about some of those things as we go through the rest of the panel. And I think these things will obviously apply to climate as well, which affects all kinds of human health beyond just cancer, of course.
Great. Well, I'm the biology nerd on the panel, and our company was actually founded by 5 MIT grad students / professors. I apologize, I went to Harvard for both of my degrees. Thank you for having me. The thing I'd like to get across, though, is so to me, like AI is a tool. It's one of many tools that we use. What is particularly interesting to me about this moment is that AI will develop superhuman capabilities very quickly in the field of biology. And the reason that matters is because, in my mind at least, biology is probably the only substrate that is actually capable of solving the problems that everyone here today is discussing. Climate change, food security, human health. Like, we are made of biology, we eat biology, and biology made the atmosphere and the planet habitable. The reality is that humans are no good at biology. We did not invent it. We invented language, we invented math. AI tools are like starting to catch up to humans in those areas, right? We have a really high bar because we created the thing. AI is just getting a little faster. It's pulling things together for us, but it's not, until very recently, doing anything that felt all that interesting, exciting, novel, because it's competing with us at something we created. We did not create biology, so we don't understand biology very well. We call it drug discovery, not drug engineering. We don't actually know how to engineer biology today. That's what my company is working to figure out. And the thing that's so exciting to us about AI is that there is so much biological information out there that follows no human readable patterns or understanding. They don't follow rules we recognize. And AI is right now, the tools that we are developing right now are the only thing we have seen thus far that is capable of ingesting that quantum of information and making any type of sense out of it. And so what I get really, really excited about is the potential for AI to enable humans to start to understand the actual rules that underlie these phenomena, biology, chemistry, physics, that we rely on to advance scientific understanding and solve the types of problems that we're talking about today. I'm also a skeptic, I've been a skeptic, I would say, for many years about AI in this field, because the approach people have been taking is, oh, we're just going to develop better algorithms, and that's going to solve all our problems. I think these are immensely harder problems than anything else we've had to deal with that AI has been tackling thus far, image recognition, human language, things like that. And so my view, and one of the things we're working on a lot, is that we're going to need to do a lot more sort of real-world experimentation, reinforcement learning, you might call it, like old school stuff, in the field of biology in particular, to generate the kind of information that will actually be needed to bring these models to a point where they're useful and that they're solving some of these problems. I don't think we have nearly enough of that yet. But I'm similarly a skeptic, but also unbelievably optimistic for the potential of this type of technology to actually advance a field that has candidly been stuck for about 40 years in terms of what it's able to accomplish.
Fantastic, thank you. So before we move on to broader topics, so for each one of your application domains, so there is at least I see a health link, or one way or another, but maybe different levels of tolerance of error by a given algorithm that would apply. And so there's that one angle that I would like to explore with in each one of your application domains. And the second one is, given that that bottleneck in terms of tolerance for error, because of how the output of the algorithms would be used, what are the other bottlenecks that you see with respect to the data itself, given that these algorithms obviously are entirely dependent on the data, not just amount, but also quality, but also in some way standardization and control in terms of how it has been generated and collected. So if you can speak to those challenges and where you see essentially the bottlenecks, but also the opportunities, or if there are any even applications of AIs that would just we would not be able to reach given just inherent limitation in the data quality or amount in your application fields. Apologies.
So I guess these are two very broad topics and big topics. We could spend an hour talking about each of them. I'll go to the data first, and I think a huge problem is bias in data sets. Bias arises from a variety of different forms, and when I say bias, it is not my premise that individuals are nefarious in terms of how they assemble data and how they analyze it. Case in point, most of the clinical trials, the early clinical trials that have looked at the success of some drugs, a big drug called a beta blocker, which lots of patients with cardiovascular disease are on, like 60 to 70% of those are white men in the trial. So understanding how these drugs actually act in different subgroups has come along with time. Data sets, especially the ones that are retrospectively collected, are inherently biased. And moreover, whether we all want to recognize it or not, we all are biased, right? I think that's not a heretical statement to say. This is because it's a part of human nature. And these biases can enter into our analysis of data in ways that are difficult to dissect. So the data itself can be biased. Our analysis of the data, essentially models inherit the biases that we have. And that is very challenging, very, very challenging to tease apart. With respect, and in my view, at least in my domain, I think that is one of the biggest challenges towards developing models that are robust across many different populations. With respect to tolerance for fault, my tolerance for error with respect to these models is 0. And we will work until the models are perfect. Why? Because cardiology, cardiologists walk around, we think we're the most important doctors. Sorry. Because many of the decisions that we make are life and death. When you miss a model that gives you incorrect data and you use it to make an incorrect decision with a patient, results in a loss of life. If it's 1% of the time, that's really bad if you're in that 1%. Or if that 1% falls to a loved one or a family member of yours. So one of the failure modes here, and it's related to tolerance, is not only understanding the success, because we typically look at the success of these models based on standard statistical measures. What's the overall accuracy across a population? What's the discriminatory ability? But we don't think a lot about the failure modes. When is it likely to fail? And I think that is an important obstacle towards the general success of these methods in the clinical domain. So I'll shut up. I'll put my soapbox away.
Oh, that's a great point. All right, what about for you, Sherry?
Yeah, so in our domain, I guess the applications are different from in human health, but still related. I'll give an example that I think pushes back on this idea that we're aiming for systems with zero error. Not that it shouldn't be the case in cardiology, but in our case, a concrete example is predicting income levels or wealth levels using a whole suite of data that we have available for the first time, like cell phone data or satellite data. And this has actually been deployed in practice in Togo. So there's a Nature paper written about this from some of our collaborators. And they used a combination of, I think, cell phone data and satellite data to predict things like wealth and also whether crops are growing at a particular location. And during the COVID pandemic, they used predictions to basically determine who to hand out aid to. So if you're lower income or if you're a farmer, you get a certain type of aid. So this obviously has a lot of impact on people's lives, whether they receive money or not. But you have to think about, I think, what the counterfactual is in that situation if you didn't use this AI system. The counterfactual is using much less granular data to dole out aid, or just doing it at random, or just basically using maybe historical survey data, things like this. So if you think you can improve on this, I think one could argue that it's kind of your moral imperative to use the better model that you do have to assign aid, even if that model is far from perfect. And what we see in a lot of these development domains is, in fact, that the R squared of your model's predictions versus the ground truth is actually not that high. So the signal that you get from cell phone data, from satellite imagery, is a very imperfect or very incomplete signal for a household income or wealth, or whether someone's growing crops. But still, an R squared of 0.5 is better than what we had before, and so one could argue that we should be using this information even if there's still lots of errors. I think, yeah, so I say the counterfactual, I think, compared to what we would be using is very important to consider as well.
And that's very field specific.
It is very field specific, yes. Although I will say with self-driving cars, as another example, I think we're already at the point where the cars make fewer mistakes than human drivers in aggregate, but they're not widely deployed today, even though I think you could argue that they might save lives if deployed, but there's other considerations beyond just pure accuracy in that case.
Yeah, and that touches on a point I want to come back to after on the trust or the human interaction with the output of these models. But maybe let's go first to you, Matthew, and then
Yeah, I mean, I think that's a really interesting point because we accept zero error from things like that, yet it may actually be safer in the aggregate, but that's...
You've never made a mistake.
I've never made a mistake. Exactly. Although, yeah, so there's a number of things here to unpack, and so maybe I'll build off of offer a perspective on a couple points that Colin made. And the first is starting with data and really which kind of begins to speak to risk tolerance. So the first one is that medical data is imprecise, and in fact, medical data is often not what people think it is. People take it as ground truth, but it is not necessarily what's there. It's actually quite biased, and the bias even beyond the issues Colin brought up, and I'll give you a concrete example. I was talking to one of my colleagues yesterday, in fact, who did a beautiful study where he basically used language models of the medical record to predict, based on people's visits, who was going to get diagnosed with a specific type of cancer, pancreas cancer. Nature paper came out. For him to actually pull this off, he had to go to a specific data set that was the country of Denmark. Number one, he needed a much larger data set than you could get from any individual health system, but he actually realized that the way people would do this in the US, which is based on something called ICD-9 codes, if people know what that is, they actually discovered that those codes are actually not accurate, right? there was actually an issue that led to delay in publication of the paper for a year because they realized that the way medical data is recorded in the US is not accurate enough to actually support what they needed to do to run the models. And so they had to come back and basically address this, and it actually is a huge problem. And that's because lots of medical data is actually billing based. It's based on what you can bill, not based on what the patient actually has. So we can argue why this is the case, is it right or wrong? But the bottom line is the medical record is an invoice. The medical record is not necessarily a medical record. And that is just a hard reality that we need to accept, okay? So we can say that we can try to fix that at a policy level, but I would argue that's not going to be the case. I would argue this is the challenge is how do you deal with the imperfect data if you want to make such predictions. Now to get to the risk tolerance. Maybe in cancer we have a slightly different risk tolerance because if you have a diagnosis of pancreas cancer, you're probably not going to do very well. And if I can find you earlier, you're going to do better. So that actually makes a big deal if I can find you earlier. So, but this actually comes to what can we expect to learn from, like what can AI tell us? I don't think it's ever going to tell us this patient has this disease and this one does not. It's a statistical model, which is actually how medicine is practiced anyway. All right, if I say there's, I don't know, roughly probably 200 people here in the room, statistically one of you might have a cancer, all right? But if I run the same test on all of you, I'm never going to find it because the math just will not work out, okay? So, but if you show up with a defined set of symptoms, which is what doctors do, and those symptoms make it overwhelmingly likely that, you know, if you show up and suddenly I say I'm having crushing substernal chest pain, he's going to turn over. And now suddenly the likelihood I'm having a heart attack jumps from very, very small to very, very high. Now you don't think of that as actually a statistical model of doing it, but that is actually how medicine is practiced. And so we may have to retrain actually how we think about medicine if we are going to apply these algorithms. It shouldn't be the test comes back and says you have this. The test comes back and says you have an increased risk of this, and now you use that as an additional bit of information that has to be built into either computer generating models that help you further narrow down risk groups or humans. I think initially it will be humans, but we can also turn to other examples where, you know, things where AI has been successful, at least in the cancer space, pathology, radiology, okay? If you happen to be in Boston, you're very lucky. You can go to MGH. You have the best pathologists in the world and the best radiologists in the world who will read your scan. But if you're where I grew up in rural Wisconsin, you may not be as lucky. Now, there's good doctors everywhere, right? But you never know, right? And the studies have been done on this, that agreement between what is ground truth, right? It's 5 radiologists agree, 10 radiologists agree. Turns out computers are much better at eliminating bias from these things, right? They can actually eliminate all these things and say, well, we read this is what the computer sees, and it doesn't know the difference if it's in rural Wisconsin or if it's in Massachusetts. Now, that I would argue, and studies have shown this with like molecular testing, that this can actually elevate the accuracy of subsetting cancer patients into the right groups. And so this is a great application of where artificial intelligence and machine learning could actually truly help people. Now, is it going to be 100% right? Absolutely not, but the doctor isn't 100% right either. And that's why it's interesting to unpack, like with self-driving cars, like any accident is unacceptable, even though I bet if we did a poll here, more than 0 of you have gotten in a car accident at some point in your life.
Great.
Probably a little bit more optimistic on what, I don't think it's AI, but where technology will advance in terms of our ability to understand what is happening in a human body with a relatively simple test. But I would echo the points that have been made around the sort of limitations of AI to eliminate sources of bias that exist in the data. I feel like we've covered that ground. Maybe a twist on that and getting a little bit more into the trust piece. One of the conversations I have a lot is if you're in the optimistic camp of AI getting superhuman very quickly in terms of what it will allow doctors, researchers, et cetera, to do, learn, understand, develop in the field of biology and human health. It also creates the opportunity for human beings with AI tools to do the opposite of that, to learn how to manipulate biology in ways that we don't think are appropriate. And so I've been having a lot of conversations now about AI safety and AI trust, and how do you trust that that AI tools are being used appropriately, how do you build safeguards in to ensure that they're being used appropriately, how do you ensure that even trustworthy systems, or theoretically trustworthy systems, are in fact giving drug candidates or other recommendations that are in fact trustworthy. And I think there's an opportunity right now, because candidly I do think biology and human health is a hard enough problem that it's not going to be solved overnight. There's an opportunity to think more critically about this issue before the technology supersedes our understanding than we have done in other fields, where we are currently playing catch up and regulators have absolutely no idea how to put the cat back in the box for ChatGPT and the large language models in images and human language. And so one conversation that I think is useful to have among the academic community, among regulators, among private companies, is how do we encourage the rapid development of this technology and the opportunities that it brings, while also recognizing that this will be a much harder in the field of biology, which both has huge opportunities. That will be a much harder technology to control and regulate once it gets better than we are. And it's doing that very, very, very quickly. And so I think useful conversation to kick off in these types of settings as well.
So I want to bounce back on the trust question that you pointed to. So there's the trust in the answer, and then the trust, with respect to its absolute accuracy that can be quantified in various ways depending on how it has been trained, et cetera. But then there is also even if we have a very highly accurate algorithm, there's the question of how do you get also the adopter, if you will, of that answer to ultimately really trust the answer. And that I'm thinking more directly into the medical application, where you have now a direct action or essentially use of the result to influence patient care, for example, that there is in that domain a direct potential link and application of the answer on essentially modifying the system that it was used to do the analysis. On the other hand, there is the more passive approach of where the answer is not necessarily going to lead to an action in the system, but just an evaluation of next step in the study, or a potential next step that's less impactful directly in changing the system itself, if I compare the various fields here. So can you speak a little bit more about that, again, more from your field point of view, but then more broadly? So I see a lot of potential challenges with the direct human application in medicine, because there is also the human algorithm interfacing, right, of being able to argue why the algorithm arrived at an answer and not being really able to discuss that, obviously. And so how do you convince, for example, medical colleagues that disagree with your diagnostic, versus applications that are also impactful, but maybe less tangibly in geoengineering, for example, or other discovery of drugs or treatment?
So I guess I do agree with much of what was said previously, and my statement previously about trust and tolerance, rather than 0% tolerance, is about when do you know that you're done. It was my statement. It was not my statement that things should not be adopted unless they're perfect. I don't think that's a realistic point of view, and I'm not completely a pessimist. I believe in these methods. We work in this space. I just believe the greatest advances in this area come from the pessimist and from one who takes a pessimistic point of view. With respect to the adoption question, I think it's an important one. So you have a healthcare provider, and I'm going to speak from the point of view because that's one of the only things I know something about, who you want to adopt a particular technology. And people tend to adopt things that they are familiar with. that are consistent with their prior understanding of disease and how patients are treated. Physicians, healthcare, have undergone medical training. Physicians have gone to medical school. They've learned about the body and working in a particular way. And when you give them something that does not jive, or they cannot recast within that framework, within their prior understanding of medicine, and doesn't use prior concepts that they have learned, then it can be challenging. So in instances, I think, where these models are quite complex, it's hard to dissect them and to explain them using a corpus of words that the physician is familiar with. So I want to put it in simpler terms. So if I were trying to explain the Heisenberg uncertainty principle to a Shakespearean scholar, that conversation is going to be very different than if I were trying to explain it to somebody who had a physics course in the past. So trying to explain these concepts, one has to have an understanding of what the prior concepts the listener, the user, has in order to make the explanation. And these sorts of things don't go into the design of the model. These models are designed with a particular purpose, to optimize some loss function typically, and how they end up working and whether these prior concepts are encoded them are not clear. There is a class of models, and people have been working on, some of it was alluded to in a previous talk, in which one tries to embed mechanistic models or models that have this, and I think those have actually a lot of promise of being easily developed. At the end of the day, however, I think, aside from this aspect of explainability and understanding, which I do think is important, there have been many things in medicine that we have adopted that we don't completely understand. But the adoption happens after the trials have come through. We have a sense of how accurate they are, and we have a sense of what patients they're appropriate to be used in and what patients they are not. So I think in the setting of things that are opaque, they should ideally undergo the same process, the same rigorous process, other sorts of interventions in the medical field. And for therapies, that has been randomized trials, many subgroup analyses, and so forth.
Yeah, I think the trust question is related to, I guess, who is the end user, what is their tolerance for error, and what is the counterfactual. So I think in many of our cases, I think we haven't had to deal with trust a ton yet in a lot of our applications, but we focus more on how can we validate the performance of the model with high quality data, and that's really the piece I think we have to get right when we develop our models, is making sure we have some gold standard ground truth that we can really evaluate the model on to show performance. I think because the counterfactual in a lot of these applications, for example, wealth mapping or mapping what farmers are planting on the ground and how they're doing it, because the alternative is really kind of non-existent in a lot of what we do. It's just national level data, county level data at best, rather than a map that can show you a very high resolution what's going on our planet. Because that's kind of the state of the art previously, I think the trust issue hasn't come in quite as much, because it's just, yeah, this is a big improvement relative to what we've had before. But I will say, I think for systems like these upcoming like GPT or LLM-based extension agents, for example, that's directly interacting with a farmer, and the farmer can say, here's a picture of my crop, can you tell me what's wrong with it, or what I should do? Should I buy fertilizer? Should I buy pesticides? What should I do to improve my yields? You know, that, I think when there's those individual interactions, there's more of a trust component. But again, I think there, too, the counterfactual is a lot of times this lack of access to any kind of extension service. So this is such a new technology that I think, of course, there are risks when you maybe tell them to spend their money on the wrong thing, and that could be catastrophic in some cases. So I think when you develop these systems, you definitely have to evaluate model performance, and especially in these extreme cases if you take the wrong action, and it could be devastating if you took the wrong action. So minimizing these like extreme bad cases. But I think in many of those cases, a farmer could have repeated interactions with such an agent, like such a chatbot or whatever, and learn what kinds of tasks this agent is good at, and adjust their own understanding of how to interact with such an agent. So basically, I think there's things that the user can learn too from repeated interactions.
So I think that brings maybe another theme we'll come back to, but there is, that's what I was hinting at. There is the training of the user as well. So if we're thinking about the physician, that's definitely, if this becomes really, standardized tool in practice, then there is a whole new level of training of physicians to how to interact, trust, evaluate, or complement the output before making any essentially integrated decision. But maybe we can come back on that later.
Yeah, I agree with everything that's been said, including what you just said, and that is, increasingly maybe we need to rethink medical education about how we actually build these things in, because it is a different, it's not going away, and it's in a different approach, and how to work that into how we think about medicine and medical care might be appropriate. I think one of the challenges of applying these things in medicine, at least in terms of clinical decision making, is exactly what Colin said, right? It's that doctors are trained first to do no harm, and we know what we think we know. And I know many of my clinical colleagues, they hear people talk about Emma, and they're like, wait, machine doesn't know better than my clinical judgment, right? That's what they say, and they have this negative reaction to it. And I think the black box nature of it is part of what they view as the challenge. But I could push back and say, and Colin, I'm actually interested in your take in this, there are ways that computer reading of material exists in medicine today, and people don't think twice about it. EKGs is the one I can think of most. So EKG is something he does a lot more than I would ever order, but you get a computerized read when the EKG comes out, right?
Which I never look at.
Which he never looks at. And I would definitely look at the EKG myself, because we're trained in internal medicine, and him being a cardiology doesn't read it. But I think we're fooling ourselves if we don't think there's lots of doctors who get that and read it and take it for what it is, or at least take it, should I be worried about this or should I not? Should I call him or not? And doctors are very comfortable with that. You're not, but doctors are very comfortable with that, even though they don't understand it, right? So it's not that they can't get there, it's that it needs to be built in and understood. But I agree, there also needs to be a level of rigor in clinical trial that is applied if we're going to use these things in there, which I don't think there ever was, probably for the computerized EKG read. However, I would also say probably the easier place is actually what you do, and that is understanding biology to, say, discover a new drug or a new intervention. Well, the test is going to be in the clinical trial that medicine actually already understands how to do, and it's going to work or not going to work. And that is probably the place where the impact can come, because even if you don't understand how you arrived at the answer, it's either right or wrong, and we know how to test that.
Yeah.
And it's also lab-generated data with high precision, so.
Yeah, I don't worry as much about, well, let me put, in our field, to your point, we don't worry as much about the trust issue because we don't understand anything, so it all needs to be validated in a lab anyway. But in some ways, I also think it might miss the point a little bit. Like, we're having a conversation about trust because the users of this technology on this panel are highly trained experts in their field who are using an advanced technology. One of the reasons I'm concerned about this technology, or not, maybe concerned is the wrong word, but trust of AI is not the issue we're facing right now with something like ChatGPT. Trust in AI is not going to be the issue we face as biological large language models become more widespread and accessible, and as biology gets easier to engineer. Like, we have the cybersecurity industry for a reason. We need to build a security infrastructure around this technology as well. And it's not a trust issue, it's a security issue. And right now we don't have a biosecurity infrastructure. We certainly don't have a climate security infrastructure. I think these tools can be part of building that. Like we will need AI to combat all the risks that AI generates. We will need AI to combat all of the risks Mother Nature throws at us and human beings more broadly. But to me, it's not a trust issue. And in some ways, the trust issue becomes a little bit less relevant if you have a robust enough security infrastructure that can find breaches in trust quickly.
So I think so linked again to, I mean, how much time do we have? Nothing? Okay, all right. All right.
You can have like a 2-minute wrap-up if you want. If that's
Sounds good. So maybe just to wrap up, and you can jump in less of that time. So I think if I summarize a little bit of the points here that we touched on, there is clearly not a generalizable application of, let's say, one class of algorithms to the various fields. I think that there's very different levels of accuracy, different levels of data quality or amounts in the various applications. In some applications, that's actually a very good alternative to use. In some others, there is still a lot to develop to be able to use them in any decision-making loop that would actually impact the field itself directly or the outcome of the patient or the system. And overall, I think there is sort of a mixed feeling of great opportunities, but skepticism and needs that are not just about the algorithms, but also about that data generation, source integration, and essentially standardization to really move to the next step of integrating the tool in the fields in particular. So we leave it at that. Thank you.